Well, a very good evening, everybody, and welcome to this edition of What Now, What Next, which is the alternate roadmap featuring our health professionals panel. Tonight's going to be a really exciting night of discussion, hearing from our health experts in terms of an alternate way forward with COVID-19. We know that we've all done a really tough time in Victoria, and we've seen Victorians experiencing probably the toughest period in our lifetimes. They've been challenging, and certainly we've seen both many lives and livelihoods lost as a result of this pandemic. The key now is to look at a sensible way forward with bearing in mind the importance of ensuring the health and well-being of all Victorians is paramount. And that is why in this edition of What Now, What Next, we wanted to start with this health professionals panel first. We have with us also tonight a great audience featuring just over 100 different people, which is amazing that we've got over 100 on the chat. And welcome to all of you. Give us a bit of a wave. Excellent. And tonight's session will have me firstly asking each of our panelists, our four panelists, firstly with Dr. Geoffrey Wells, followed by Dr. Sharon Hoch, Dr. Richard Bloom, and Professor Catherine Bennett. Each of our panelists, I will ask them a few questions each, and then we'll open up to the audience afterwards for some questions and some discussion. So let's kick it off tonight with firstly Dr. Geoffrey Wells. Dr. Wells initially trained in Scotland. He's a highly sought after urologist with more than 30 years of experience. But notably in the context of tonight, he was the lead author of a famous letter to Daniel Andrews, which had over 500 doctor co-signatories to look at the discussion about an alternative approach to the pandemic. Dr. Wells, welcome. And if I could firstly ask you, why did you write this letter to Daniel Andrews and what were you hoping to achieve?
Thanks very much, David, for inviting me for this session. My colleagues and I were discussing various aspects of what's going on in Victoria with the COVID virus, and we really got quite concerned of the Victorian government's management of the coronavirus. So we thought we better write a letter to Daniel Andrews and just let him know that there were many experienced doctors out there that thought there was an alternative view to that of the CHO in how to control the COVID virus. So it's a 5-page document. It took us 3 or 4 times to write it. Then we got it proofread.
And
we said,
sorry, just to interrupt.
We sent it off to Daniel.
How many people signed it? How many people signed
it? Initially 13 people signed it. Then we got a website. One of the people, Eamon Matheson, organised a website. So then 600 people have signed it, David.
Yeah.
We've sent it to Daniel Andrews. Unfortunately, we haven't had a response. I've sent him a couple of text messages and furthermore, no response. The basic premise of the letter is that the lockdown, we believe, is causing more harm than good. And we're quite concerned about this. I mean, our heart goes out to the economic community, to the business community, when we think of job losses and companies going into liquidation, etc. And it's terribly, it's awful. But we actually believe that the medical effects of the lockdown are going to be more excessive than this and could be catastrophic. A couple of reasons for this. Delayed diagnosis in cancer is one of them, and I think Richard might talk a little bit about that. But secondly, the mental and social issues we think are really, really awful, really depressing. So we're looking at depression, anxiety, and the fear factor in the community. About 85, they've done a poll, 85% of the population have a fear of the virus. We know that self-harm is increasing, and at the Children's Hospital, that's increased by about 30%. Domestic violence is on the way up, and generally there's a whole aspect of fear and just concern in the community. It's awful. We're just seeing it in the patients all the time. I was just telling people earlier, the isolation that people are feeling, it's really, really disconcerting, and we're seeing it all the time.
And in terms of writing that letter, and in terms of the decisions that are being made at the moment, in terms of, we see the Chief Health Officer every day pretty much with Daniel Andrews, who do you think is actually making those decisions, and how would you like to see that change?
Well, that is an excellent question, because as far as we know, there's the Chief Health Officer, Brett Sutton, and the Chief Medical Officer, Dr. Wilson, who's a cardiologist. But apart from that, David, we really don't know who's making the decisions. There's no transparency, but what we would really, and I'm just not sure what is happening here. Are these people in a bubble, or are they oblivious to what's going on in the community? Because, you know, we're the people at the coalface, we're the people seeing the patients. They're isolated, I would think, in their government departments, and it's all a one-way ticket for them. There doesn't seem to be any pushback. So what we really wanted to do is get perhaps 6 doctors, get 2 psychiatrists, 2 geriatricians, 2 GPs with an interest in healthcare, and sit down at the table and actually speak to these people and let them know what's going on in the community. Because if things don't change, then, you know, it's just going to get worse and worse and worse. And as I said, I don't know whether they're oblivious to it or what's going on, but it's not good at the present time.
Well, thanks, Geoffrey, and we'll come back to you, because you mentioned that part of this was actually looking at having some GPs, 2 GPs on that panel. And I'm going to cross to one of our GPs that we've got now, Dr. Sharon Hoch. Sharon, welcome. Sharon's works as a GP with experience in both rural and metropolitan general practice, who is currently also working in an inpatient aged care COVID unit. And I won't say where, but it's local. She also has a unique experience of being a clinician managing patients with the virus, as well as also having tested positive with the virus herself. So she can talk from both levels tonight. Welcome, Sharon.
Thank you. Thank you for having me. It's a pleasure to be here. I'm very excited.
And Sharon, could you firstly tell us, with your experience, both as a clinician on the front line and as a patient, and has it altered your understanding about the pandemic and its effects?
Well, when the pandemic first started, I was like a lot of other people, and it just seemed like initially another very bad flu in a very populated area. So hence the high death rate in a small, densely populated region. We've had swine flu, New Zealand flu, avian flu, various things over the years. And very quickly I realized most people don't know my background is actually, I used to be a cellular biochemist with a minor in immunology. So when I started watching the symptom profiles and seeing how this thing was behaving and starting to turn into the pandemic, I started looking at genomes and virulence and things like that. So I very quickly learned, and yes, I have had COVID, and now I'll clarify for everyone at the moment, I didn't get it from a patient. You're a lot safer being in full PPE, managing a known COVID case, than going to Chemist Warehouse where people maybe don't wear their mask and cough and sneeze, and you're exposed to you don't know what. So our infection control was great on the unit. I was just unlucky, unfortunately. Some processes fell down elsewhere that I was, and I copped it. I've also had the misfortune of having influenza a few years ago outside of the vaccination period in November, when it had a mini epidemic. And I can tell you it's nothing like that. I'm grateful to my patients because I saw what it was like before I got it, which was both helpful and terrifying. And just to give you an idea, the unit that I worked on was a subacute unit. So these people were not in ICU. We didn't have an ICU. We didn't have full IV care. We didn't have people on respirators. We had people that were mild to moderate disease, some asymptomatics as well. But I was fairly well versed in the way the virus behaved prior to. However, I will say when I was tested, I was asymptomatic. The only symptoms I'd had was I'm a shocking hay fever sufferer. My symptoms prior to being unwell with COVID were itchy throat, itchy runny eyes, runny nose, nothing out of the ordinary for me when I'm cleaning the house or in spring. And it wasn't till about 3 days into my illness, besides the fatigue that hit pretty quickly, that I actually started getting the textbook list of symptoms. So that's one of the things that was really confronting, is that I was asymptomatic. And that's where I spoke to you, David, about one of my biggest concerns is you go for this test and you get this fantastic state government flyer, double-sided. The first line says, if you have symptoms, go directly home. And I'm like, hang on, if you've needed to be tested and you think you needed to test because of whatever reason you think you need a test, you should be at home. You should not be shopping. You should not be visiting your auntie. You should be going home until that result comes through. And that's what started this journey for me, you know, with sort of trying to bring this to people's attention. I'm like, Geoffrey, I feel for you. I wrote to Jenny Mikakis twice initially, thinking that the health minister would be the best person to start with. I copied Dan Andrews into the first email, wrote to him directly again, have written multiple times, have called, and nothing at all. And it's very disappointing because the first line of the information that you get when you have a test is wrong, because some of my elderly patients were asymptomatic and never got a symptom the entire illness course, and afterwards they were no different the day they walked in as the day they left. So it's a big piece of misinformation that's putting our community at risk, because you may be spreading it and you've got no idea what you're doing.
So thanks for that, Sharon. And you bring me to the next question that I've got for you. So obviously the testing is a really important component. And then the other side of this is the contact tracing. And we know that going forward, and one of the big issues that we have had so far in Victoria that is different to the other states, is the fact that our contact tracing has not been up to scratch. And I know that was one of the reasons why you contacted me a few weeks back in the office. Could you explain to our audience what are some of the issues around contact tracing, and give us your first-hand experience of that?
My first-hand experience was I was sick with COVID. So within 24 hours, I was actively unwell with COVID and got worse. And to the point where in my illness course, I actually had quite a few days there where I had to decide whether or not I was going to go to a hospital, because my oxygen levels had gotten so low on those days. And I sort of managed to manage them and knew clinically how to do that. And it was from the outset, there was very little they got right. Now, to give you an idea, my background, one of my subspecialties is in sexual health, so contact tracing is not new to me, because all the communicable diseases in sexual health are all reportable. My details when I called, my name was spelt incorrectly. My age was out by 10 years. So when people ask about the stats, well, if my age is out by 10 years, that took me from a group that was most at risk in the beginning to a group that really wasn't at risk at all, by the numbers. And the biggest issue is they have this weird process where when you correct a mistake, it has to go off and be emailed into another department to be authorised. Those authorisations don't happen. So errors such as names, dates of birth, date of testing, date of last exposure, when you should be retested. A lot of those, I'm a family of 5. I'm proud to say, because of my measures that I took at home, working on the unit, no one in my family got that. I have 3 children, a partner, no one got sick with COVID, no one tested positive. But I, from my sick bed with less than half a voice and short of breath, was ringing the contact tracers every day to every second day saying, no, my son got this text that's incorrect. No, my daughter, you know, this information. They didn't even contact trace my daughter, and their excuse was they didn't have her phone number when they had the same form. She filled in the same form that everybody else did. And in case. She's a teenager and they should have been contacting me.
So the big kicker that you explained to me was when you returned back to work after getting a letter from DHHS, you had them door knock you. Can you explain that one to everyone?
So I was cleared late on a Saturday evening. My family, of course, have to stay. So that was day 11 for me, based on my symptom profile, etc., which was fine. Family all have to stay quarantined for 14 days. So they should have come out of quarantine midnight on the following Tuesday. And all the troubles I had, I was going back to work on Wednesday. I had to have, as a health worker, 2 negative tests, physical tests, to return into the health workforce. That was fine. So I did that over those couple of days. And I purposely delayed my start to work by 24 hours to make sure that my family were clear from DHHS. I rang the contact tracers and said, right, they're coming out of quarantine, etc. My husband had to go back to work as well that next day. So this was the Wednesday, and I get a message from my son, first of all, saying that he's been told he's not out of quarantine, when they told me, read their computers, that yes, he was out of quarantine as of midnight the night before. And then I get this frantic call. I had 3 teenage children at home, 2 of them are remote learning, and the COVID door knocking team with the ADF show up at my door. And I was saying to my teenagers, where's your mum? And my son was, saying, well, she's at work, and he didn't know if he'd said the wrong thing. And I said, no, sweetie, you haven't. You've just told the truth. It's fine. But it was terrifying for my teenage kids to hear that the military had been at their door over something that I'd purposely, and it was 40 minutes. I was on a COVID unit. I don't use my mobile phone on the unit. I won't put it up to my head, just germ factor. We sterilise and use the ward phones. I wasted 40 minutes of time when I was supposed to be caring for aged COVID patients.
It's terrible.
It was disgraceful. And then they tried to ring my mobile after I said to them while I was on the phone, they said they're going to call me. I'm not going to answer my phone. And then strangely enough, I never had another call. Now,
so just to be clear for everyone out there, so this is after you got the letter from DHHS to say you were good to go. You still waited beyond that another day or so.
4 hours, yep.
And then you were back on the ward and they were door knocking you, trying to find out where you were.
Yeah, and they knew my place of work because they had to ask me because of all the, when you're eligible for pay and where do you work, and they check all your salaries and everything to see if you're eligible for any money from the government. That's a standard question they ask no matter what industry you're in. So they knew where to find me anyway. I mean, where was I going to go? I needed a work permit to be there.
Yeah.
I was actually very calm through the whole process and tried to really work with DHHS, with the contact tracers, correct the mistakes, make suggestions the whole way along. I can't believe I was so patient, because what I learned with COVID is it also brings about a bit of a mood change. It's not just normal grumpy, it's actually an agitation I've seen in my patients as well, and a confusion in the elderly that's different to normal delirium. And so it was challenging, and I was still so patient with it, but by the last day I was angry. And I told them, I said, I'm really livid with you. You went and you harassed my children. That's not on. That's acceptable, at my home.
Well, thank you, Sharon, for sharing that with us. We'll come back to you through the panel a bit later, but we really appreciate your honesty and sharing that firsthand experience. I now want to cross to Dr. Richard Bloom. Richard is a leading plastic surgeon in Melbourne, specialising in breast and body surgery. He's previously served on the Council for the Australian Society of Plastic Surgery and as the chairman of the Plastic Surgery Training for Australia and New Zealand. Welcome, Richard.
Hi, David. Thanks for having me.
Pleasure. So I want to ask you, particularly if you can describe the situation around people not going to hospitals that are obviously not COVID related, but those that may be concerned for their own health of going there, and what pressure that may be putting on the hospital network at the moment.
Yeah.
Or into the future.
Yeah, so as you've heard from Sharon and Geoff, I mean, patients are scared to go not only to hospitals, but also to see their doctors. And we've heard of incidents already of patients having heart attacks and other medical emergencies at home because of all of this reluctance and fear. At our surgery, which is largely elective, we've had patients who haven't been able to get mammograms or have had troubles getting mammograms before breast surgery, as well as patients putting off having skin checks for skin cancers because they're too afraid to get them checked. And this can all be incredibly dangerous. And on top of that, we're going to have missed colon cancers and a whole host of other diseases. So there's just not enough information out there for people to make an informed decision, and that they think making an appointment is going to be incredibly risky, and we're going to get late diagnoses of very serious conditions. I mean, it's now been a week, nearly a week since there was an announcement that we're going to go back to some degree of elective surgery in metropolitan Melbourne on Monday. But if you go to the Department of Health website, even this afternoon, there's been no update. So it still says that you can only go to a medical specialist when an urgent consultation is required. So now that you can have an elective surgery, you must be able to see your specialist before the surgery. I mean, that just makes sense. So if we, as a medical practice, are confused, I can only imagine what patients out there are feeling themselves and not knowing what they can do and can't do.
So I would imagine, in terms of a whole lot of people that would be waiting for some kind of surgery or some health support into the hospital network, that would cause enormous pressure on the health network going forward. Do you think we've got the resources to be able to cope with that once we finally get ourselves going again? And what pressure does that put on doctors, nurses, healthcare workers, admin? Has that been factored in, do you think? Or do you think that this is going to be a massive failure in our health network going forward?
Look, I mean, Australia's got one of the best health, if not the best health system in the world, David. And there's a lot of incredible people who work in it. So everyone will find a way, but there are a number of concerns, and all of these could and should have been addressed very quickly and efficiently. So, for example, elective surgery really could have continued, with the exception of maybe a few weeks in August, throughout this entire year, provided there was adequate PPE and staff, which for the majority of that time there was. Some hospitals could have been designated purely for elective surgery with correct protocols in place. Some bigger hospitals with multiple operating suites could have been preserved for potential COVID patients, but a safe, efficient use of hospital capacity with fit patients having low risk surgery, high value surgery should and could have been implemented early and safely. Instead,
So just to be clear here, so what we had for months are pretty much empty hospitals. Yeah. So they weren't being utilised. People were pretty much, standing around. We had obviously a lot of focus on the COVID stuff, and appreciate all of that. We're now in a situation where we've got another wave, if you like, but not of COVID, but a wave of health support and further surgery that's needed. And on top of that, we've got an exhausted workforce of nurses and doctors that have been working on COVID that potentially might need a break. Isn't something going to have to give with all of that going forward?
Well, I think it is. And the problem is the tools that were used were very blunt around deciding who could have surgery around a public hospital waiting list category system. And urgency probably should never have been the only measure in terms of who could and should have had surgery. So, other factors should have come into it, like the length of surgery, the complexity of surgery, the length of stay in hospital, risk of complications, the need for ICU, also patient factors. So, operating on patients with comorbidities and the elderly, that was not really looked at, where we could have been getting through some of all this elective surgery tidal wave that's going to become. And we could have just used the hospital resources more efficiently. And there's talk now about an elective surgery blitz, but it is, as you're alluding to, it's concerning on how and when this is going to be done. And it's not just the doctors that we have to consider. We have to consider all of the healthcare workers, and many of them have carried a significant load, as we all know, through this pandemic. a number of healthcare workers, and I'm not just talking about doctors, but nurses, clerks, orderlies, all of this, the other staff that go into making a hospital work, they have all carried the burden through this pandemic. And if there's going to be a hospital, if there's going to be an elective surgery blitz, well then these people haven't had a holiday. By the time we get to Christmas, these people wouldn't have had a holiday for 7 months, and they're going to be asked to work weekends, after twilight lists, which are afternoon lists, and maybe not even going to get a holiday. And that's not even taking into account all of the patients, David, who haven't been seen for their consultations over the last 6 months. They're all going to be have to be added to what is going to be an enormous waiting list. So it's going to put a massive burden on some of these people who've been really amongst the hardest hit through the pandemic.
That's really concerning. Thank you very much, Richard. We'll come back to you shortly. I now want to cross to Professor Catherine Bennett. Welcome, Catherine. Just a little bit of background on Catherine. Professor Bennett is a renowned epidemiologist and specialising in communicable diseases and community transmission. She has appeared predominantly in the media to help people understand the processes and complexity behind the numbers that have been reported each day, as well as supporting evidence-based and balanced interventions of COVID containment in Australia. So again, welcome, Catherine. And I know you've been called on a bit to kind of explain some of the modelling and look at some of these alternate pathways that we're discussing tonight. We're seeing some good news of late in terms of the numbers. And there's obviously a real thirst to get people back to business and back to work and get the state up and running again. The real trigger is, of course, October 26th. And based on the recent numbers, are you optimistic that we're going to achieve those targets?
Yeah, look, I mean, that is the good news tonight. We've now had 2 days, well below 20. And in fact, when you look at the projections based on these average numbers, the average daily numbers, taking into account our 2-week pattern, we are tracking very well. And in fact, we look to meet the numeric targets for step 3 pretty soon after we meet, and we've already met the targets for this step 2, this smaller step that's coming up in a week's time. So I think that is really good news. And I think, at the end of the day, we probably didn't think we'd get there so quickly. It's very hard to predict how a tail of a pandemic, wave will play out. But I also think with the numbers we're seeing now and the ability to work so comprehensively with each case that we find, that we could reasonably expect for those numbers to continue. So I do think we could start October with numbers in the very low 20s, if not the teens, and shortly after we could continue to track to get below that 5 and hopefully have excluded those mystery cases in the process as well.
So in terms of the restrictions that are going to be lifted after the 26th, do you believe, given the current circumstances, could some of those be safely lifted now?
Yeah, look, I think we're probably better off now looking at trying to bring that whole step forward rather than cherry pick bits of the interventions, bits of the restriction, I suppose. Because I do think we're talking about a position in a week, maybe only a week beyond this next step where we could be looking at that. There has been, a lot of people listening very carefully to the words of the Premier and hoping there'd be a shift on this tying the step 3 to time as well as to the metrics. And that's still a bit unclear where that might go. They are talking about, updating models and looking at the daily numbers and particularly the stories behind those cases. But there still seems to be a sense that you have to lock into a set date. And to me as an epidemiologist, we've already factored time in to these metrics. That's why we hold them for 14-day averages to make sure they're not fluctuations. So I'm hoping that conversation about being fixed to a point in time does shift and allows us to bring everything forward Otherwise, the public health messaging isn't clear. You know, if you tell people that we're going to lift the curfew, but we're not going to, you know, you still have to stay within 5 kilometres or whatever, it gets confusing. All of that said, there may be particular elements that relate to key activities, and we've just talked about some in relation to elective surgery and so on, that should be looked at perhaps even independently of these stages as we get our numbers down. And just finally on the targets, I was just recalling we asked about this when we were going into stage 4, what the end looked like and what we needed to aim for. And my recollection is, certainly my view, we needed to get our case numbers double figures and low double figures. And, you know, under 20 is what I was suggesting. And in particular, to have those very low case numbers for those mystery cases they talk about, ones where they're missing a link and there's probably a few more cases out there. And I think that was kind of the view at the time. So it's interesting now that we're having a much more strict conversation about what that looks like. And, you know, that's where we're at. But even so, we look like we're going to meet those targets as well.
So it seems, and if I pick up on what Dr. Wells said at the beginning of all of this, and we've heard it obviously repeated with Richard and others, that there's this real fear. And I know that, you know, when we've kind of asked that question about easing of restrictions, that people are really concerned that as soon as you take the foot off the brake, we're just going to see those numbers hugely escalate. And I suppose this comes back as well in terms of the whole idea around suppression and elimination. Are we in a situation where we're always going to have some numbers with us and we've got to learn to live with this? Or are we kind of in a scenario where, you know, we're right now because of what we've done and we can stick with those single digit numbers going forward? So if you could answer that, and I might then come back to Geoff in terms of answering that as well.
Look, I think there has been a lot of sort of polarised conversation, which I think probably helps fuel some of the fear that you describe out there as well. You know, at the end of the day, suppression is the path to elimination. And when you look at what we achieved after the first wave, and we weren't measuring community transmission, so we don't know how extensive it was. We know it was there. We saw the more severe case end with people hospitalised with community onset pneumonias. And some of our serology data might hopefully enlighten us on how much, you know, wider spread there actually was. But we eliminated the virus that was circulating at the time. And we opened up from, you know, in that first sort of big step in mid-May, when we still had 17 cases, 25 cases the next day, linked to that cedar meats outbreak. And yet we were able to contain it. And we know our contact tracing was nowhere near as sophisticated as it should be now. And so, you know, you can close down even reasonable sized outbreaks without being in full lockdown. So I think that should give us, you know, optimism that we could still be suppressing this, even if we did in the end get stuck at 10 cases per day average, and the government decided we'd have to open up and give up on this, you know, even smaller targets, that in fact that could still be enough to ultimately eliminate. While we're in lockdown, it's a better chance to make sure that you're not seeing insidious community transmission like might be happening in New South Wales. But at the end of the day, it doesn't mean you can't lock down. So whether you settle for 10 instead of 5, or whether you go for 5, but you go on the 5th of October when we hit the number rather than the 28th of October, it doesn't change the possibility that you could in fact go for elimination. But you're right, David, even if we did achieve elimination, the virus came back into Victoria. It was reintroduced. It's clearly happened in a similar way in New Zealand, and the virus made its way from Melbourne to Sydney. And at the end of the day, we have to live with that reality that none of our borders can be impermeable completely. And we have to be, even if we eliminated it on the continent, you'd still have to have your monitoring, your surveillance, your outbreak detection, and your response all set up to go to keep it in check should you find the virus has landed again or it's emerged from within community where it's been sitting undetected for a while.
Terrific. Thank you very much for that. I might just quickly cross over to Geoff. Did you want to add from that any more to what Catherine's just said?
No, look, I'm obviously not an epidemiologist, and I respect Catherine. We've had a great long chat last week. But I certainly agree. I mean, New Zealand seems to be a place in question where they thought it was suppressed or eliminated, and then it came back. I mean, I basically think that we've been in lockdown for 6 weeks now, David, and I tell you, there's a lot of social, as I said earlier, there's a lot of social disharmony. I think if, it's a balancing act. I mean, we can stay in lockdown for another 6, 8 weeks, and we can really destroy livelihoods. And I think what's going to happen, the suicide rate will probably go up. It's a bit of yin and yang, and that's where, as sort of compassionate doctors, we've got to, I think someone has to step in and say, look, we've got to learn to live with this virus. It's a part of us, and we can open up, we can get back to some normality. We've got to be strict. If you're an elderly patient in your 70s and 80s, now we know if you get the disease, if you get the virus over 75, the chance of dying is 11%. Contrast that with if you get the virus under 60 years of age, your chance of dying is 1 in 150,000. So one of the other things I'm always a bit interested in is people haven't been talking about the death rates as much as about cases. Well, I think if you're a 75, 80-year-old patient, a bit of self-determination, I don't know we always need the government to be telling us how to live our lives. I mean, if you're a 75, 80-year-old lady, my mother's 90, she's incredibly sensible, and she says, look, I mean, I've had a great life, but I want to keep on living, but I'll just self-isolate somewhat myself. But that doesn't mean she doesn't want to see her relatives. That doesn't mean she doesn't want to see her children, her grandchildren. So, I think as Richard said here, we've got to be sensible here. We just can't be numbers people. We've got to be compassionate and look at the whole thing. I mean,
whole picture, yeah.
Absolutely, yeah.
That's terrific. And this has been a fantastic introduction to this panel. Really, really good conversation. I'm now going to open up to our audience, and we've got 123 people on the chat tonight already, which is fantastic. And I'm going to start with the first question that I've got, and that is from Gino. Gino, if you could unmute yourself and ask your question, please.
Well, thanks for that, David. Look, my question is, if I can give you a bit of background, in 1996, Victoria closed off the Fairfield Infectious Diseases Hospital. I spent a short term in that hospital in 1990. And you talk about fear, and I can tell you I was genuinely fearful when I was there. But my concerns are that we have no specialised hospitals in Australia for the treatment of infectious diseases. It's resulted now in infected patients using general hospital facilities, creating risks from airborne super spreaders like COVID. And we've had others since 2000. We've had SARS, MERS, Zika, Ebola. They've all been, we've known all about them. And they create risks. Importantly, what it does is exposes general patients in general hospitals, and importantly, our doctors and non-specialised nurses to this. And I'm finding the numbers of infections amongst our health workers particularly troubling. My question tonight, and for people like Catherine, based on our experience with COVID, is it time to reopen or build a dedicated infectious diseases hospital in Victoria, offering specialised training to nurses and doctors, and a facility where we can really quarantine an outbreak like COVID?
Okay, terrific. Thank you very much. Over to Catherine.
Thanks, Gino. A really good question, and one that I've heard many of my infectious disease physicians, thinking over, not just now, but in previous years as well. I think it is a loss, as you say, even as a training site and really bringing together that capacity. We did have a lot of cases. We do have an issue around, I guess, a distributed outbreak as we had in this, which when it was statewide, that makes it a challenge having a central place to bring people to. But it certainly, could work in combination with a spokes and hubs model where you could, in fact, still set up things regionally, like we're now trying to do with our testing and contact tracing, that actually distributes that expertise, to the areas where it's needed. There's also a lot of talk now about, coming back into the conversations nationally around having a national level of capacity that could bring together the expertise, the clinical, the biostatistical modelling, the epidemic, the laboratory, all of that coming together in a way that could support states and provide surge capacity to states when you have a situation like Victoria, where suddenly, you know, everything was really happening in Victoria these last couple of months. So I do think there'll be greater thought put into our resources and our capacity going forward. And I'd really like to see, you know, that sort of idea of building that clinical expertise, whether it's one hospital or whether it's something virtual that links different places, or it's something that can be, you know, mobilised very quickly in response. All of those things have to be looked at as part of our way ahead.
And just on that other part of that, I might ask Sharon as well, in terms of pressure on our health professionals and some of the risks that they're dealing with at the moment. Sharon, could you comment on that?
I think a part of the issue in the health, I think with the health workers sort of run of health workers, what I discovered was there seemed to be quite a difference in some of the types of training and levels of training that people were getting in their infection control. So people were doing what they thought was absolutely correct, but then the information's updated, and like Richard said before, things get updated, but the information isn't put out there on an even keel in an even way, except for the most recent change about when to doff your gloves with PPE, which was the first time I'd ever seen a universal thing put out by the state government that went, this is how we all need to do it. And these little glitches are happening. I mean, I got the role in the COVID unit from Surge Workforce, which I signed up for in about March or April when the call out from the state government happened. And, you know, I put my hand up, and then, as Catherine said, you know, I had some level of expertise, and the rest of it, you know, I educated myself and then felt confident enough. There was a big call out, and lots of 13,000 healthcare workers put their hands up. When it came to filling spots on that unit, we struggled, and we ended up with 2 doctors on site running a unit for 8 weeks.
Yeah.
Full on for us, 2 doctors, but we did it because we were dedicated to it and committed. So that's the thing, is this sort of universal need to have the information, get out there and get out there. If they have the knowledge, then put it out there. Where's the delay? Why is this happening? Why is it not actually coming? Because what the thing is a lot of these mistakes that people are making, some of them, yes, we've got our civil rights activists and, you know, anti this and anti that, but some people genuinely believe they're doing the right thing. And it's not till after someone gets infected, or then a family member subsequently dies because they're elderly and they contracted COVID from them doing something they didn't know was actually wrong, because the information isn't universal and it's not put out there quickly enough. Yep. And I don't understand how people are dragging their heels, because plenty of us, as Jeff said, and Richard said, we're all here to put our hands up, you know, and yes, too many cooks, but if a few people get appointed and they say, right, within 24 to 48 hours, this gets put out there, that's what's got to happen. Yeah. Time lags that are causing these waves.
Yeah. All right, I've got another question now from Jenny Robertson. So Jenny has a question to Catherine. Hang on, you've just muted yourself again. Sorry.
Unmute.
Yeah, perfect.
Thank you, David. My question is as much to Geoffrey and to Richard, actually, as it is to Catherine. In the legislation that was passed a couple of weeks ago, Daniel Andrews has effectively legislated for eradication of the virus. Given that only one virus has ever been eradicated, that is smallpox, what do each of you think will be the practical way forward for Victoria and for Victorians to resume life similar to what New South Wales and Queensland and South Australia have, given that no coronavirus has ever been eradicated effectively or an effective vaccine found? All
right, so we'll start with Jeff.
Well, I think that's an excellent question. And I think it's certainly, we could take a leaf out of New South Wales book, I think. Daniel Andrews, I think, is, I'm not sure if he's a little bit concerned that perhaps he feels there might be a guilt factor even in what's happened previously with the hotel quarantine business and the security guards. And I think maybe he's could be overdoing it a little bit. I think it's going to be very difficult, as we've said, to eradicate it. And I think, I think if he actually met a few more people in the community and we could get down and talk to him, he doesn't seem to be talking to people. He doesn't seem to be talking. I've spoken to a few business leaders there. They don't seem to be able to get to speak to him. So I think he's one of these people that's in a little bit of a bubble. I think, as I said, as the French president said, we've got to learn to live with this disease. So I totally agree, Jenny. I'm not an epidemiologist, but I don't think we're going to be able to eradicate it, unfortunately.
Richard, could you add to that? Would you like to add?
Well, yeah, thanks, Jenny. That's really the question going forward, isn't it? And unfortunately, we can't run a counter narrative, so we don't know if we would have done less and just got out with precautions and hand sanitizing and masks and social distancing. We don't know, but I think we can hold out for a vaccine, but I don't think that should be the strategy, because we can't stay, as Geoff keeps saying, we can't stay cooped up for another 6 weeks. I don't even know if we can last another 6 days, but I think we're going to have to at some point pull the trigger and put in measures with social distancing, hand sanitisation, and those things, and have a number that people like Catherine are happy with, that we think that we can contact trace and follow and chase every single case down, so we don't have outbreaks and shut areas down. And that's what we're going to have to do going forward, and until there is a vaccine, or if there is a vaccine.
Thank you. Joe, I have Joe Gara, who's got a question.
Was I just
oh, sorry, yeah, sorry, Catherine. Yeah, please.
Thanks, Jenny. Absolutely. We cannot eradicate this, and the words are thrown around, but incorrectly in most cases. And so we're not looking at eradication. Local elimination of transmission is probably now possible for us to contemplate again, because we've gone through 10 weeks of strict lockdown up to now. And we should take any gains we can get from that now that we're in this position. But at the same time, I do think, as Richard said, it's about how we map the way ahead, and even if we don't see local transmission, if we still have to be then prepared for either it re-emerging like New Zealand, reintroduced or whatever. And there are ways you can do it. It's not just, having our contact tracing teams, primed and ready to go. There are smarter strategies we can do around contact tracing, going to the contacts of contacts at the same time, so that you actually, in effect, do isolate, but not a suburb. You actually go to the people who have a risk of having picked up the virus and ask them to isolate through those linkages. We have very clever monitoring, the sewage systems, wastewater monitoring, all of that could help once the virus levels are so low that those do become signals of virus in community, and then can trigger other strategies for detecting where the virus is and what we need to do. So there's definitely ways we can go ahead. And I think our past success should actually give us the confidence to know we can do that, and try and allay some of these fears that we've either got to stay in complete lockdown until the virus is completely gone, because that's actually not true. And it's our own story, and stories overseas show us what can be done.
Just before I leave you, Catherine, and ask the next question, I did want to ask some of the issues that we had been finding in terms of Victoria tending to recreate the wheel on a lot of this stuff. So we have seen things like New South Wales had their first outbreak with Ruby Princess, and they had to go through some pretty swift contact tracing and management of the virus. They've obviously had modelling in other states, so we've got people on our doorstep. Yet it seems as though we're going it alone in doing a lot of these things ourselves. Why has it taken Victoria so long to pick up the phone and talk to New South Wales, talk to Queensland, talk to some of the other states?
Yeah, look, I think there's been a pattern to this that's been described elsewhere. It's true of data and data sharing. It's true of learning from each other in terms of contact tracing. New South Wales has a very different regionalised health system, and that's given them some advantages in the response, because they can get a local fast response with people who are already engaged in local community. But equally, they've had to deal historically with the challenges of keeping hubs talking to each other and having that communication work. And so there's a lot they can share with Victoria now that Victoria's realised that having a regional hub system as well as now a metro one is a better way to go. So of course you learn from your neighbours. So it's frustrating we couldn't get some of these things up faster. Some are because you do have to build the infrastructure, so there's a delay. But I absolutely agree that learning from others, sharing at this time is critical. And I think that's part of the argument about having a more, following on from the National Cabinet now meeting, which I think is one of the good legacies of this, equally having those abilities to, have a national coordinated response that brings the best expertise to every state as they need it and keeps the message consistent and coordinated as well, which is really important with that, the best, latest information, being fed to everybody in a timely way, as Sharon said, that's critical.
Yeah. It is very frustrating. I know even in my position as a Shadow Minister for Police, talking to police commissioners and alike, there's a regular weekly, fortnightly hookup of commissioners all around the other states. And the other states were doing things with things like hotel quarantine, having the police in control. And it seemed, really disappointing that there wasn't that sharing of how other people were doing things, and the fact that Victoria had to go alone on some of these things and make mistakes without learning from others that were kind of well and truly had the game sorted. If I could go to our next question, which I did call on a minute ago, and I'll probably have to find it now. It was Joe. Yeah, Joe had a question.
Yeah, thanks, David. Question, guys. In GP land, what I find hard is actually, one, convincing patients it's safe to come and see us because they're so scared of stepping outside their front door because the government's done such a great job with scaring everyone rather than just being careful. And the other problem I have is hospital outpatients are often operating at half capacity and they don't seem to want to see anyone. So it's proving really difficult getting care for patients. How do we address that? Any ideas how we get the government to change its messaging that it is safe to go to your doctor, it is safe to go to outpatients and get these outpatients open? I mean, in Werribee, the maternity outpatients is doing phone consults.
Yeah.
So they're checking pregnant women over the phone, which I think, well, it's ridiculous. You can't do that over the phone.
Yeah, Jeff.
Yes, I'd agree, Joe. We were just saying I had a GP that rang me up and he was telling him about a lady, a patient with swollen ankles, and the nurse, he wasn't really welcome to come into the nursing home if he could avoid it at all. So he did a teleconference, and the lady had swollen ankles. He gave her some Lasix. She was voiding fairly frequently. The nurse rang back 2 days later and said she's still voiding fairly frequently. So he thought it was the Lasix, so he cut the dose in half. Then they rang back another 2 days later, and the woman was very unwell and she had urinary sepsis and needed oxygen, antibiotics, rehydration. So teleconferencing has its certain limitations, and it's difficult because a lot of our patients, I know I've stopped going to Box Hill because I'm just there as a consultant, but the people who are still there saying that all the outpatients is teleconferencing basically, and it does have a few advantages, but across the board it can be a fairly poor substitute on a lot of occasions, I'm afraid.
So we're getting inundated with a lot of questions, and I know we're coming close to our end time. I'll make just a couple of comments and then I'll go to the next question. I know Tatiana had a really good point, how much of restrictions imposed are actually based on medical advice, with the revelation of the curfew wasn't based on medical advice. Looking at New Zealand, we had a question, had 120 or 130 days without the virus and then it reappeared. So how realistic is us to eliminate the virus? And I think we've discussed some of that. Here's another question I think worthwhile just touching upon from Kieran. Kieran, could you ask your question?
Hello, yes. Thanks, David. Can you hear me? Hopefully, okay.
Go for it.
Yeah, excellent. I'm an emergency doctor in southeast Melbourne, so I've got a fair amount of exposure to this sort of stuff on a daily basis. Look, fundamental to my question really, I guess, lockdown's sort of designed to reduce morbidity and mortality in the community. And really, I posted a link for a Sydney Morning Herald article there by Vice-Chancellor Duncan Maskell from University of Melbourne about what's our tolerance for death in the community, which I don't think we're talking about at all, because I think maybe it makes us all a bit too uncomfortable. But really, I think something we need to talk about is, given that this virus is not going to be eliminated, we've got to deal with it, is at some point we need to balance the ruining young lives, school children, adolescent, young adults, sort of ruining their lives, depleting their super and so on and so forth, versus saving the life of someone who's in a nursing home, who has had a long life prior and has multiple comorbidities, including dementia. I mean, I've seen countless examples of these people that have been the ones, I mean, I haven't dealt with many COVID people myself, but the people in the majority have been nursing home patients. You know, I think the concept of quality adjusted life years lost from the elderly losing their lives to COVID versus the huge impact that has on young people, mental health, financial, so on and so forth. I think we have to be a bit better as a society of talking about these things more honestly, and being brave enough to sort of venture into that sort of discussion.
Could I throw another spin on that question to our panel as well? We've locked everybody down essentially in Victoria, and particularly in Melbourne. Taking Karen's point, where the most vulnerable are our elderly, could there or would have there been a better approach, and I know that was touched on by the panel earlier, in which we give more protection on our vulnerable and, you know, effectively use a bubble approach on those that are vulnerable as opposed to lock everybody down? And well, ask anyone to answer that question.
David, I think Catherine brought that out very well, I believe, a couple of weeks ago when she spoke about a two-pronged approach. And we haven't really spoken about this now, but, you know, we're not underestimating the virulence of the virus, but we've certainly got to look after those in nursing homes, treat them with care, compassion. They're the people that have built this wonderful country and this wonderful state we live in. But by the same token, if you're young and fit and virulent, well, you know, there's the people, if we use social distancing, we use common sense, then sure, we can let these people get on and live a lovely life, a beautiful life like we've all lived in the past, how Victoria used to be.
Yep.
I was going to just flag in there, I don't think it's a matter of that we can put a value on one life over another.
Yeah.
Instead, they built what we have today. If it wasn't for our elderly population, we wouldn't have what we've got.
Exactly.
But it's about putting in the right parameters, using common sense, and also being respectful. This is something I flagged. Lockdown happened and the waves happened because some people do actually outwardly go and do the wrong thing. Some people, you know, the government's only now, the hospitals are only now bringing in screening for people in COVID-heavy areas where we get screened once a week. It's voluntary, but we have the option to be screened once a week. We don't have to miss work because we know we're using PPE and everything, but just to catch those people that may have been exposed that don't know that they've actually caught the virus, are asymptomatic, you know. And when it comes to our nursing home patients, it's about family members. Go in, visit your family member, put the PPE on. Don't hug your nana or your nonna or your yaya or whatever. You have to, and look, I've got a 92-year-old grandmother. She's, you know, cognitively not all there. I've said to her many times over months, there's a virus, it's a bad virus. If I get sick, if you get sick, you might die. And she doesn't really remember every time when I speak to her, it's still, why haven't you come and seen me? You know, but it's about us all being responsible and taking responsibility for each other. It's not so much a matter of civil rights as people's civil responsibilities, just to not do harm to others. That doesn't mean that we shouldn't be able to go and hang with our friends. And you know what? You don't have to go if you're 17 or 20 and hang with your friends. You don't have to hug them at the moment. You can refrain, right? those little measures which make us a little bit sad and we'd rather do it, but that will ease things down the track when we've got a better handle on things and when we are understanding things more and getting control. So I don't think it's a matter of putting a value marker on, well, they're old and they're nearly dead and that, because clearly, unlike me, you've never had to ring the family members of people that have passed and say, I'm really sorry, you know, and we know it's COVID. It wasn't there, whatever else they had, comorbidity, kidney failure. I watched them die from COVID related symptoms.
That's a really important point, Sharon. All life is important. I'm going to give a final thought because we've heard from Geoff and Sharon in the last question. A final thought from Richard, a final thought from Catherine, and then we'll wrap up. Richard.
Look, David, governments make cost-benefit analysis all the time. And the example that was given to me is we don't put pool fences around every single garden to stop unnecessary deaths in swimming pools. We just put them around swimming pools. So there can be a more nuanced approach, and I think that's where we need to head to.
Yep, sorry. And to you, Catherine.
So, and I was just going to agree with that. I think when this started for us in February, March, we really didn't know what we were being hit by. And we're in a much better position now to take an evidence-based, nuanced approach to how we manage both community transmission more widely and how that impacts on particularly aged care and what other pool fences you might need within aged care to guarantee a quality of life, but also perhaps an extra layer of security. And a lot of that looks like it is management of the workforce, the ability, you know, to set up systems so you don't have people working across aged care facilities and all those other things that we've now learned so much about. So I think we can manage risk and we can do that very well. And I think, you know, we should have moved beyond the time where we need blanket restrictions because we don't know what's going on or what will happen. We should be in a much better position to map a good, clear, evidence-based path ahead. That means we can, you know, live a life and live with the virus.
Fantastic. So I think we've learned some great things tonight. Firstly, all lives are important. The fact that unfortunately in Victoria, we've got a situation of fear and we've got to be able to get ourselves through that to be able to get back to what is normal going forward. I think the very, very important thing is that the caring for one another, which is absolutely paramount. And I think particularly the fact that we've heard today that, and we know that we've reduced the numbers, we're getting back to these kind of numbers, but largely we would expect that because we've been locked down. We've been completely locked down and our ability to be able to communicate with one another have been very much limited. We know that we can't be locked down forever. And that's got to be the thing going forward. We've got to get a balance. We've got to be able to return back to getting kids back to school, getting people back to work, and ultimately return to some kind of normality going forward. And I think the approach that we've heard tonight has been very sensible. I think the idea of being able to get more expertise around government to be able to share that expertise, particularly with medical professionals that are looking at the health aspect, the mental health aspect, and certainly all the others considering being able to deal with our healthcare network going forward are really important considerations. I wanted to thank our panelists tonight for a riveting conversation, a really informative discussion. Firstly, to you, Geoffrey, thank you very much for the work that you've done. To you, Sharon, thank you. To you, Richard, and to you, Catherine. Thank you very much for your conversations. And we'll give a big wave and a clap from everyone if we can get a bit of a clap going. Terrific. And I wanted to also finally finish to our audience tonight. Thank you for joining us on our own reset of What Now, What Next. This is the first of a series of 6 discussions. Next discussion will be next Tuesday at 7 p.m. We'd hope that you join us for that. We are going to look at the future of small business and the events industry. This is going to be a really important discussion because Victoria was the home of tourism, events, and certainly the service industry of yesterday. The Melbourne, most livable city, came to be that way because we know we had overseas students coming wanting to study here. We had tourists wanting to come and enjoy Melbourne. We had great sporting events, which now we've lost the MCG, the grand final from the MCG to Brisbane. And we need to look at how we get this reputation of Victoria back. The discussions that we'll be having in the next few weeks is to return Melbourne, return Victoria to where we were. We've got to be positive, we've got to have hope, and we've got to see where our future lies to ensure we can all get everything back to what is normal. So please join us with that discussion next Tuesday. And to all of you, thank you very much. To everybody watching this, stay safe, stay well, and please, if there's anything my office can do, please don't hesitate to reach out. Thank you everyone for joining us, and we'll see you all next time.